how do we need to shift our conversation? And I think both Matthew and I would argue that autism acceptance is a big part of where we need to start shifting the conversation. Matthew, do you want to talk a little bit about what some of the important distinctions between sort of awareness and acceptance are?
Sure. Um, when you're made aware of something, it's because there's something different, and something strange, something weird, something that's different from the norm. And the first instinct of humans when we have something new that's different, that's strange, is to fear it or to other it. And I think 20 years ago, when autism wasn't as prevalent, or at least the diagnosis of autism wasn't as prevalent, um, there was a time for it. But what it tends to do is it keeps people from accepting autism as a different way, as opposed to a strange way or a wrong way, or something that needs to be corrected. And moving towards autism acceptance allows you to see autism as an acceptable part of the way humans are. It's not as common, but it's still it's not something to be scared of. It's not something to be feared. There are, it doesn't take away the fact that there's challenges, but it does focus on a lot that there are a lot of strengths.
Okay, so we've got our slides, so let's dig in. So can I get the next slide, Lisa? So some disclosures first. So for me, my relevant sort of funding disclosures are that I have research funding from CIHR. I have some other federal research funding, and then from Autism Speaks. I am, I carry many types of privilege with me. I'm white, I'm cisgendered, I'm heterosexual, I'm neurotypical. We're also, it's also important to, I think, acknowledge some other things about privileges and where we are and live and work. So I live and work on land that is the traditional territory of the Wendat, the Haudenosaunee, the Chippewa, the Anishinaabe, and most recently the Mississaugas of the New Credit. And then Matthew has some disclosures as well.
All right, so I'm a self-advocate. I'm autistic. I do not receive any money for my advocacy work. I am a white, bisexual, non-binary, disabled autistic, which is a mouthful. I live in rural Eastern Ontario in the traditional territory of the Anishinaabeg, Huron-Wendat, and Haudenosaunee, St. Lawrence Iroquois people, and this territory is covered by the Upper Canada Treaties.
So our objectives for this presentation. So there's so many things we could talk about, and indeed our initial meeting to discuss what we could discuss went on like twice as long as scheduled. But this is sort of what we've landed on. So we want to talk about the importance of language and considering the language that you use to speak about autism and about behavior. I think in clinical work, we're often confronted by kind of how families are interacting with autism and responding to it. So being sensitive to the emotions experienced by families, but also how to help them how to help you build acceptance into your clinical care. We want you to feel more comfortable addressing questions of curing and treating autism, which are some of the things that again come up somewhat frequently. And then also to be aware of some of the risks of non-acceptance. So when this process goes awry, what might you see and what can you do about it? Okay, so let's talk about talking. So what's the big deal? So how we talk about autism is very important, particularly I think at some critical junctures where we might be likely to see these things come to the fore a little bit more. So those discussions around those first signs of autism, The diagnostic feedback to the family is certainly one where we talk a lot about what autism is. Um, Assessing and helping with interfering behaviors is also another critical juncture, and one that we often talk about in our Echo Autism case discussions. Um, and then also, like in general, like how can we incorporate more strengths-based language instead of deficits based? And I think here about a lot of times when we're discussing cases in Echo Autism, we'll get to kind of partway through our discussion and someone will sort of say like, what does this kid like to do? Or like, what is this kid good at? And I hope that those are questions that we can start bringing into our clinical dialogue a bit more. Um, because they are not just important for how we conceptualize autism, but they're also really key important pieces of how we provide the right types of supports. Okay, so language quagmire number one. Do I use person first language, which would be person with autism, or identity first language, which would be autistic? And I think first and foremost, if you are in an individual clinical encounter, the best thing you can do is ask someone's preference. So we're learning that a lot more right now with, how people, what, for instance, what pronouns people prefer to use. And this is just another example where we can show that we're considerate by asking people's preference about how we describe autism. Um, if you are looking at kind of broad trends, and these are not by any means prescriptive or 100% the case, person first often tends to be preferred by parents. Again, not necessarily by all parents. And then identity first tends to become the preference of many autistic youth and adults. So in general, I think beyond asking preference, if that doesn't happen to work out in your particular situation, follow their lead and think about how you can be flexible. Matthew, did you want to chime in with anything there?
If we go to the next slide, I can chime in.
Okay.
Because that's a good segue
Oh,
point.
perfect. Okay.
So, talking about identity, this is an area that there is a lot of friction between parents and professionals and self-advocates. Teens and adults who are autistic, generally, by quite a majority, prefer to use identity first language. And people in other disabilities, are very similar. Deaf and blind folks tend to prefer identity first language. But then people say, but autism is separate from the child. Like you don't talk about it. Like my child has autism. That's not part of who they are. So let's talk about other places where we use identity first language. I am Canadian. I am a father. I am a son. I'm right-handed. I am white. I am a Sens fan. Sorry, everybody. Now, if we were to flip all that to person language, right, to put the person in front of everything that's part of us, I would be saying I have Canadianness. I have offspring. I have parents of which I have maleness. It took me a while last night to figure out, how do I phrase that and not have it sound wrong? But the thing is, it does sound wrong. I have right-handedness. I have whiteness. I have a fan interest in Sens. And if I said it all in one sentence, it would be more of a mouthful, and I'd have to take a breath. A lot of us feel that the reason why autism is part of identity, as opposed to being something separate, is every single part of us, every single thing that we think, every single thing that we do, our actions, our reactions, are all done through the lens of autism. We can't separate autism from ourselves. It's like we can't put it away so we can go on vacation. It's inevitably a part of how we do and think, and we've come to accept that. It's not to say that we don't struggle with it. We don't have challenges. It doesn't challenge us. It doesn't put barriers around us, but it is part of who we are. And so many of us prefer identity first language as opposed to the person first language. But when it comes to talking about a person, just put a note here. If you're talking about a person, talk about the person. You don't necessarily need to say, let's talk about Joey that who has autism, or let's talk about Joey who's autistic. Let's just talk about Joey, right? If we want to talk about the autism, talk about how it the effects, the challenges. But if you really need to use, if you're not comfortable with identity first language, and you're concerned about person first language offending people, a neutral use would be on the autism spectrum. It's something that a lot of us can accept because it's not separating us from it, and it's not saying who we are. So we can see that as a happy medium.
So we also had a chat about some other times that kind of this language comes up that can, in a subtle but probably important way, influence people's ideas about autism. And so we were thinking about, and these are some that Matthew flagged for me that I hadn't thought about. So red flags, already is really introducing a lot of kind of negativity into that discussion, or when things are first identified. And so you could say something like possible signs of autism or early signs of autism, depending on the situation. And then one that kind of, I think, blew my mind a little bit was thinking about switching language from challenging behaviors to interfering behaviors. And I think part of it again is just kind of like shifting the frame of who we're talking about, right? So we are often the ones challenged by the behaviors, and yet when we think about interfering behaviors, like these behaviors, we're acknowledging that these behaviors are interfering with the autistic person's quality of life, or their daily activities, their activities and participation. Anything you wanted to add on that, Matthew?
Yeah, the whole discussion about behaviors is a tricky quagmire. What a lot of us see is that behaviors are a form of communication, and the behaviors that you see in an autistic person may be challenging to you, but it's not necessarily challenging to them. And so if we really try to shift everything to a strengths-based, child-centered way of approaching supporting autistic children, if we flip it to looking at the things that are interfering, it's just the shift focuses on what's affecting them as opposed to what might be affecting those around them. There's still, interfering behaviors may interfere. They may be behaviors that interfere to themselves. They may interfere with others, but it's a bit different than challenging, because challenging has this. When something's a challenging behavior, it's something that needs to be fixed. But if it's an interfering behavior, you want to help guide them around it.
Okay, and then I think Matthew had some more kind of language suggestions on the next slide too.
Yes, this is what a lot of people are beginning to ask me these questions, to how to change some of the phrases that they're used to using. So when we talk about autism, a lot of the language talks about symptoms. But if we talked about the characteristics or traits instead, those are then neutral. They're not a symptom is usually something that's wrong, but a characteristic is something that's there. And it's actually important when this language is important as we start diagnosing adults that didn't get diagnosed when they were children, because it's harder to see the symptoms as negative if they've had years of masking, years of being able to adapt and compensate, but they're still there. The characteristics and traits are still there, and it's a more neutral way of looking at it. Deficit, use challenge, interventions, use supports. Severe, use extensive. Special needs, this is the one that drives a lot of us crazy. Special needs and special education, they're just needs. They're not any more special than others. They may have more extensive, they may require more extensive support, but they're needs. Everybody has needs regardless of their diagnosis. They just need to be dealt individually.
Matthew, I'm going to let you take this one too.
Okay, so another real big issue that a lot of us statistics have is when we talk about levels of functioning. Like I'm going to focus on low functioning, high functioning. Typically, we see it when people are talking about, well, he's a high functioning autistic. They have, and assuming that high functioning means, lower support needs. Well, autism is a spectrum, and if you, instead of looking at it as a linear, more autistic versus less autistic line, that you are somewhere in between there. I was introduced a few years ago to the concept of the spectrum as a color wheel, and each around the wheel you have different domains that you may have a degree of challenge, a degree of strength, and that can change at any time. Like if you look at what a person is functioning when you're being evaluated, that's a snapshot of today. But that snapshot could change a week from now, an hour from now, a month from now, several years from now, depending on what's happening in their environment. So yeah, and strengths in one area can mask significant gaps or challenges in another. And that's sometimes hard for people to see, because they're so used to, you get a diagnosis and this is what your child is like, and that they're on this same path, this plateau of seeing marginal increases in terms of their functionality. But I'm just going to give you an example. Somebody who's high functioning or assumed to be high functioning, and it's usually because of equating with their IQ or their cognitive functionality. Somebody who's got significant strengths in one area, but has no executive functioning strength, can't manage things, can't take remember to take the pills, can't remember to get themselves to places on time, can have significant support needs in order to be able to let them function in society, function in whatever domain that they're trying to work in. And it can change in a flash. I'm going to give you an example. For me, when I experience significant pain, everything goes out the window. And just a week ago, I experienced a problem with my shoulder that I haven't experienced, and the pain was significantly high. And I could write an article, but I couldn't deal with the fact that right in front of me, my ceiling was leaking because my air conditioner overfilled, and I didn't have a clue what to do, even how to move forward. Most days I could take care of both. I could do both things. That day, I couldn't. I couldn't even make a phone call. I didn't know what to do, and I couldn't move forward, and it just completely shut me down because I was unable to do things that on other days my capabilities in that area are as high as my ability to write. So the issue that functioning labels have, it doesn't help the child. It doesn't really at all. If you call somebody low functioning or high functioning, you either have a low expectation or high expectation, and that creates stigma or expectations that can't be met, and it's a real struggle. People that have high functioning in one area always usually tend to have a gap to an equal amount in another area, and that again, that can change in any particular day.
Okay, so we're already hoping to open it up for discussion. So have you changed your language when talking about autism? What did you change and why? And now I've lost my third question, but here we go.
What have you noticed?
What have you noticed as a result of making that change? Um, I mean, I think I would maybe start things off by saying that one of the things that I've noticed with some of these language suggestions is that it's it they're changes that are not based on emotions, but are really rooted in more accurately describing the complexity of autism, the heterogeneity of what we see. Certainly we all know that children cannot be reduced to a continuum, a straight line from one end to another, and so you know let's think about how we can perhaps be more precise with our language. And so this is not just about kind of how people feel about certain words, although that's important as well, but there's also an element here of kind of specificity and accuracy. All right, any thoughts? Anyone who has changed or perhaps has not changed and wants to tell us why? Adrian.
I mean, I'm happy to talk to the issue of person first, and Matthew, I really appreciate the differentiation between what you see parents doing versus what's meaningful for you as an autistic person. So I'm the parent of an autistic child and not an autistic person, and you're right. My first instinct is to say no, she's not only autism. But your point about the fact that autism clearly is part of all of you and that you can't separate it makes so much sense. So that resonates with me, and I have to think about that and think about how I refer to her and start asking her how she wants to be referred to. But I would validate and agree with you that I think as parents, our first instinct is to say, we don't want to only refer to someone as that, but it makes so much sense. So thank you.
Has anyone kind of made that switch from person first language to identity first language, and what has your experience been with it? Anne.
Hi, thank you for putting this on, Melanie and Matthew. I find it confusing and a little anxiety provoking. And I would say the best way forward is just to ask each person as person to person, with the respect that feels like bringing, what would be preferable. And in terms of the skills, I find it so illuminating to find out what each individual sees as a strength, like what's good about you, whatever the diagnosis. And I think that has such validity and such important weight going forward. An example would be in psychoed, very poor visual spatial skills, blah, blah, because the child happened to tune out at that time, but the child's an artist and makes sculpture. So that person-to-person contact is just so precious. So it's kind of a non-answer, I would say.
One of the things that I've noticed when you look at the diagnostic criteria for autism, you see the talk about special interest or heightened focus on special interests, and it seems to be like that's a deficit that you're looking for. But what I see is that's the strength. Like if somebody's hyper focused in a particular area, you can use that particular area to connect the child in ways that you wouldn't if you tried to normalize a way a child would have multiple interests. You know, as a starting point, that's a great place to go, because you know that's with my oldest son when he was young. He would build Thomas strings over and over everywhere and use everything in the house to make things part of it. And one time I just decided to and he would have his own sort of talking story that he would be making going along with it. And so one time I just sat down beside him. He was like 4 years old. And I started, interacting with him in that world. And he then was able to communicate to me in that world. Whereas outside of that environment that he created, and outside of that interest that he had, there was no two-way conversation. There was one way, and it was rarely him to me. It was usually me to him. But that joining in, finding that thing that he was most interested in at his level, got us a two-way communication that allowed us to start doing other things as he grew older.
Okay, so seeing no more hands right now. Let that sit and percolate. So maybe let's dive back into our to our next topic. So we're going to talk about feelings next. Let's talk about feelings. Okay, so grief is another really interesting discussion point, and I will say, as a clinician, as someone who diagnoses autism, I this really resonates with me, and I would say that I certainly see families in all of these different stages. And yet, I would say grief has understandably been a very tough and at times really hurtful um, concept for the autistic community. And we'll get to some, I think, a really good quote that I think encapsulates this in a bit. But certainly someone grieving your continued existence, you can see why that might be an idea that's sort of hard to swallow. So how can we resolve this, and what are the different, first of all, what are the different ways that you might see that someone is experiencing grief over this diagnosis? Because I do think, certainly at the end of the stages of grief, not that it's necessarily a linear process, as I say at the bottom, but acceptance is part of this. So I think as we help families move through this, hopefully the end goal is a state of acceptance at least a good chunk of the time. So some ways that I see this showing up in my clinic. So denial, I think many of us clinicians have seen this. And so we might hear things like, he's a boy, I was a late talker, anger. So sometimes that's overt, and sometimes it looks a lot like shutting down the conversation. So I can't have this discussion right now. Bargaining. It's high functioning autism though, right? And so we just had a discussion about sort of the kind of issues with that. Depression. So families who come back and they say, I just couldn't do this. I couldn't do the things that you asked me to do after the diagnosis because I felt really overwhelmed. And this process is not necessarily linear. Families can re-enter at any stage, but I think it's good to be aware of the different ways that this might present to you. So here's the quote, and I just think this is so good. So Jim Sinclair is an autistic man, and he wrote, "Grieve for us, or grieve if you must, for your own lost dreams, but don't mourn for us. We are alive, we are real, and we're here waiting for you." Um, and I just like this kind of, to distill it down into such a kind of um, insightful kind of nugget of truth. I think is just so, there's so much wisdom in here. Matthew, is there anything you want to jump in on at this point?
One thing I'll say is that there's a there, there's a concept in the past of autistic people being lost. I would flip it. Autistic people are there. It's parents and caregivers who tend to be lost of trying to know what to do, and the murkiness and opaqueness of what's ahead makes it harder for them to see what's right there.
Right. And so yeah, I often sort of see families go through this sort of in the moment, feeling like the future all of a sudden got either really hazy, or it got like there was this broad realm of possibility, and then it just got super narrow. um and I so I think my perspective on this is that these emotions are real and valid, and that we need to help families work through them, to hopefully get to a state that is going to be helping the whole family to function kind of in harmony. Okay, next slide. So, some thoughts on kind of helping parents through grief. So, I think, again, understanding where it comes from, uncertainty, fear, and like certainly stigma. So, different families from different kind of situations, whether it be, historical views, certain, certain cultural backgrounds have a lot of kind of particular ideas about autism. As an example, that in Somali culture, they call it the Western disease. Um, and so there are lots of different ideas out there about what it is and why it happens. And so kind of learning from families about that and what they're experiencing. I think a big part of the antidote can be providing hope. So, what do we all want for children, right? We want them to live, you know, happy lives. We want them to be healthy. We want them to be successful at the things that they want to try out at. And if they can't, then pick up and try something else. And that's still on the table. And so I think that's a big part of that. Hope is a big part of helping families through. And then I think Matthew was telling some stories. Do you want to tell the story about kind of after the diagnosis and going to the newly diagnosed group?
Yeah. Oh my gosh. Okay. So when my son was diagnosed, he's 21 now. So he was diagnosed about 3.5. I, again, I came out of that feeling, okay, we know what it is. We can make a plan to move forward. And the not knowing what was going on was where I had the uncertainty, where I had the anxiety. But there's, here we've got this, we can move forward. When I went to the first parent support meeting, it was one of the most difficult experiences of my life because it was so negative. It was all about venting and complaining and talking about all of the challenges and all of the difficulties with school, at home, and with getting support from government. I went to another one a month later, and it was the same thing. And it was so difficult. There was no hope, and it was all people who were dealing with kids in the first couple of years of the diagnosis, and it was like I had to not go anymore. I couldn't get support by people who were were equally struggling through this, and I found it was more support I could find with people online than I could in groups. But that does sort of go to help me go into the next slide.
Yeah, go for it.
All right, one of the things that I have learned through the many years of being a parent of an autistic, as opposed to being an autistic person myself, an autistic child at 2, when they're first diagnosed, like in 2, 3, 4, isn't going to be the same child with the same challenges. But when they're 5, when they're 10, when they're 15, when they're 21, they change, they grow. The challenges they have then aren't necessarily going to be the challenges they have in the future. And the biggest thing that parents need to see is the fact that there is a growth. No matter how challenged an autistic child is, they're going to grow, they're going to change. And the more helpful the supports they have, the more encouragement and love they have in the family, it's going to make a difference to determine where they're going to end up. But it's very opaque. It's very difficult to see that when you're stuck in where you are. And autistic growth isn't linear. It's not like a steady growth of change, of improvement, of change, grow. It's sort of up and down, all over the place. Sometimes it comes around. It's more like a ball of yarn, to be honest, that you just need to pull out. But I put on the slide here two pictures of my son. One is when he's 2.5, 3 years old, completely nonverbal. He had maybe a total of 5 words. You didn't have two-way conversations with him, and he was immersed in the world he created himself. Then there's my son at 18 at his high school graduation at a prom, and I was his date. He wanted to take me, so that was kind of cool. He went through high school. He won different awards. He has a lot of challenges still. He has a lot of significant challenges in terms of independence, but he is completely different than the child he was at 2, where the functioning was very difficult for him in any ways. He didn't speak. He now speaks. He writes music. He puns. It's not a path that you would think we would see when he was 2 years old. But this is what there's a lot of this. There's a lot of older teens and adults who are unlocking some of the ability to communicate, where they can talk about their growth as well.
And so I think, for us in thinking about this, one potential way to kind of help this out is that if you are kind of thinking about putting together a support group, trying to build it in such a way that there's a range of parents who are and other caregivers who might be at different stages along that journey, to provide a bit more perspective. Certainly you want to make sure that you're continuing to validate those very real emotions when things are so raw at the beginning. But I do think kind of seeing parents who have, and families who are kind of at a different stage along that journey, can help to provide some of that really, really critical hope, and maybe make things a little bit less murky, or at least provide some ideas of what the future could look like. Okay, so continuing on, some how grief might present sort of at the time of identification of those first possible signs of autism. So, I can often see some explanation of the reasons behind those signs. It may look like not following up, or no showing at subsequent visits. And I think here, just kind of that being that constant, I'm here if you need to talk about this, can be really, really valuable. If you are doing primary care, reaching out for those routine care appointments, and kind of talk about what what is interfering for the child in the real world. You know, what is getting in the way? What's causing the most difficulty for the family unit? And you know, kind of centering it on those real world things can, I think, help to take it out of that high level discussion of label and bring it really to a more grounded level. Um, you know, at the time of diagnosis, which is what I do a lot of my clinical time on, what I see is that sometimes I get a lot of what I think of as like spin on the ball on history. So things are coming to me with a lot of explanation built in, or this is why he's doing it, or you know, there's a lot of interpretation that's coming with those things. Usually, and for those of you who have probably heard me talk many times about kind of going through the diagnostic process, when I'm doing that feedback and I'm kind of checking in with families about what they're seeing in their child and what they told me, I might get a lot of sort of renegotiation sort of back. Well, this isn't really happening anymore, and this and this and this. They might candidly say they don't believe me. That happens sometimes, but more often it looks like kind of like wanting to leave quickly and then sort of not following up. And then if we click on the next thing, some suggestions. So there's only so much you can do, right? To kind of, you know, you can build your part of the bridge, but you can't build it sort of all the way. And so some things that I do, again, ground it really in the real world, ask for examples on history and get that corroboration from other people in the child's life. I mentioned autism early in the assessment process and throughout. I think that's just kind of preparing families for what they might be about to hear. Checking in with them through the observation. Oh, I noticed, you know, I noticed he didn't look up when you called his name. Is that something that you see at home? And then really, I think something that I will employ is pushing pause on the diagnosis. And it's a tough one and a challenging one. I think the risk imbalance here is if you have a family who's not totally on board yet, can you delay by about 6 months and then try to get some of those other things in place, give them some time to think about it? The risk of pushing too hard, and I've probably done this and it's happened, is that families may not come back to you, and so you have effectively lost more than that amount of time. I think underlying the theme of a lot of this is just kind of continuing to be in a relationship with families through this part of their journey.
One of the things that I think is also helpful when talking to parents, sometimes reframing the question. You know, if they're you know, renegotiating, if they're trying to, you know, backtrack or trying to find justifying reasons, I think reframing those questions in a different way can get the answer that they're afraid of answering. And I know it's it's also very effective when you're talking with educational people, with teachers, because their first off the cuff is they're not seeing problem. But if you ask them questions in a different way, they can say, oh yeah, he does do that, yes he does do that. And I know that was for my youngest daughter, which we brought to you know, looking for a diagnosis of ADHD. And you know, the psychologist right off the bat said, well, you know, looking at the history, said, well, we're going to look at autism as well. And at that point, the light bulb went off for me, but I know it didn't for her mother. And it was only when the psychologist had a conversation with the teachers at school and talked back with what they were seeing, did everything make sense. But it's not how we thought. And if we hadn't been prepared and the teachers hadn't been asked questions in a particular way, you know, we'd probably be still struggling to figure out some stuff.
Yeah, those are great points. So grief can also present at different time points and parents who are seeking out different types of therapy is another time point. This can look like people seeking out really biomedical interventions. And so this is where we get into some of the dangerous stuff like the chelation therapy, and certainly the bleach solution and things like that. It can be more benign things as well, but still kind of underlying that may be a desire to kind of seek out and cure or treat something something that is imminently treatable. And then therapeutic goals that are focused on normalization or cure. I think here about a discussion I had with a family whose only treatment goal was to kind of get rid of the hand flapping. And if they got rid of the hand flapping, then things would be okay. So how to help, again, this is unlikely to be solved in sort of a one-time discussion. And so, what is the relationship with that patient? Sometimes in these cases, I mean, I have limited ability to follow up, so I may refer to one of my pediatrician colleagues who I know has some knowledge of autism as well and can hopefully provide some support. Understand what they want to treat and why, and validate the real emotions that are behind that. And then here if parents are kind of willing and able, I will sometimes recommend that they read some first-person accounts of autism, because I know for me, those were the most informative in helping to shift my perspective and understand why some of these things are happening. Okay, so we have another discussion break now. So how have you seen grief show up in your practice? What worked? What didn't? What might you do differently? I can say for me early on that sometimes I think when the denial was there and was quite strong, what didn't work was pushing very strongly. And there was a time, because I think what I found myself doing was this is really embarrassing. I looked and I realized that I had like my ADOS module out, and I was going through scores with parents, and I realized, I was like, this is not where I want to be right now. This is not the conversation I want to be having. I want to be kind of not working so hard to prove that this child has challenges in these areas. I want to be thinking about how we can teach and support and how we can use strengths. And so for me, that was a real light bulb moment where I thought, I'm not addressing the right thing. I'm sort of addressing the content of the argument. I'm not addressing the emotions that are underlying it. So Roxana put in the chat, can you give some examples of first-person accounts? Yes, I have a slide at the end that has some of my my favorite books on this. And I would also suggest, if you are on Twitter, following actually autistic people. I think you'll learn a lot that way. Roxana, you have a hand up. Do you want to ask a question?
No, I just wanted to add here about, I really like, sorry, I joined a little late because I'm in the middle of my clinic. But I like, we always talk about from physician perspective, and we talk about how to diagnose. That's also a challenging thing and to learn, but I really like the topic you picked today. I think it makes us a physician, but a human too, and give a parent's perspective, how they react. And I think it's very important you were just talking about the words you pick and how you talk and your body language and I think over the period I have learned, and it does make a big difference, how you approach the parents as a parents, looking at parents' perspective. It does make a lot of difference that you tell parents or show parents that you are on their side and you are here basically to help the child. Yes, we see all kind of grief responses. I have patients walked out from my office, um, angry or not accepting what was given. I've tried in my best. I call them back and say, my doors are always open. Whenever you feel like coming back, come back. Some came back, some didn't. So I think, yeah, that's all we can do, and just tell parents that this is best for their child, like that's what you're working for.
Let's keep moving on, because there's some juicy stuff that I still want to get to. Okay, cures, treatments, interventions, therapies. What are we doing, and to whom?
I want to say, oh my.
Yeah. I love this quote from Temple Grandin, where she considers a world without autism and says, what would happen if the autism gene was eliminated from the gene pool? The autism gene was not a thing that would occur. But you would have a bunch of people standing around in a cave, chatting and socializing and not getting anything done, which I think is just a great quote, and makes us think about the very real contributions autistic people have made to our society over the years too. Okay, that's the sound of sucking air through teeth. So this topic is very, very tense often. If you have seen the dialogue online, and it's a bit of a third rail. So whether and how to intervene is certainly a contentious issue. And I think here, again, there's so much in the specificity of the language that we use and how it is often, terms are very broad and misused to mean, one thing, or terms are specific and used to apply to a whole bunch of things. One particular recent pet peeve of mine is using the term evidence-based, but applying this in a really binary way, where all of us kind of, certainly clinicians who grew up in our various schoolings, learning how to critically appraise evidence and scientific papers, know that we can't simply say one thing is kind of evidence-based and one thing is not. Where do you draw that line? It's rather more of a continuum about how confident we feel in the truth claims that are being made by by a particular paper or by a particular set of papers. And so when evidence-based is applied to type of therapy for autism, it can lead to issues. And for reference, see the history of autism funding in Ontario. ABA is another term that, again, is incredibly broad, and yet can be used by people to mean something very specific at times. So some people refer to it as meaning only sort of 40 hours a week of intensive behavioral intervention, one kid at a desk with an adult. Whereas I would say that the spirit of kind of the term ABA is something that is far more broad than that. So I think these kind of issues around language and understanding of the meaning of these terms are at the heart of some of these disputes that we have. Now, nevertheless, parents do still often ask during diagnosis about how they can cure the autism, how they can treat it, and then when they can expect that their child will be normal. And so these kind of issues are kind of exist in their most kind of purely distilled form as well.
One thing I've just
Yeah.
a thought that's come to my mind. many parents want their children to be normal. Let's talk about what normal is. Normal pre-2020 looked a particular way, but we're learning about a new normal right now. And I think that's what we have to help parents understand, is that the normal for their child is going to be a different normal than a normal for another child or normal for themselves. And 2020 actually may help this if we can phrase it that way.
Yes, we have all learned that we are in a new normal, which is another new term that I'm tired of hearing, along with supply chain and just-in-time resources. But you know, what is social communication now? We're doing this over, you know, so much over screens now. It just goes to show you how quickly the norms can change. So the quote I'm going to show is from Naoki Higashida, who is from Japan and is an autistic male. And this book goes through a series of questions with him about his life as an autistic person who is, I believe he communicates mostly through adaptive communication, so this book was sort of written with through those sort of methods. So the C word, cure. Even if somebody developed a medicine to cure autism, I might well choose to stay as I am. Why have I come to thinking this way? To give the short version, I've learned that every human being, with or without disabilities, needs to strive to do their best, and by striving for happiness, you will arrive at happiness. For us, you see, having autism is normal, so we can't know for sure what normal is even like. But so long as we learn to love ourselves, I'm not sure how much it matters whether we're normal or autistic. We were sort of thinking about different questions to ask about therapeutic approaches. And so a big one for me in talking to families is just, what is the goal? What do you want your child to learn? And so sometimes this can come into conversations about whether something is kind of building a skill versus the example of the discussion I had with the family, which was more about appearing normal by stopping hand flapping. Different therapeutic strategies place different amounts of emphasis on antecedents. And antecedents are kind of the things that are happening before a behavior happens, and can be very, very informative about what the function of that behavior is. Why is that behavior happening? Versus simply applying consequences, which may sort of build, I guess, in the next point, build sort of compliance, but may not actually address the root issue of why that behavior was happening. Matthew said to me his one of his key questions is, who is the client, the child or the parent? Which I think is such an, again, we're thinking about frames, right? Is this a child-led therapeutic approach? And then are strengths and interests incorporated? I think this is just so important as a key component of self-esteem.
So, and one thing, when we're talking about strength-based, using strengths, there is a danger of using strengths as part of therapy, you know, and focusing on, you know, making the strengths the sole focus of the therapy, to the point where the strengths no longer become important to the child, because there's a sense that they're only being validated when they're being used for therapy. And it's especially important as kids get older and into tweens and teen years, where there's a bit of a sort of a BS detector about, you know, they know that they're in therapy, and so anything in therapy can be, if they're finding hesitancy about therapy, and you're finding that they're using the things that you like as part of it, there might be a backlash against it, and that interest may disappear, which is a deficit to the child at this point. Yeah, it's the same concept that using respite for therapy. It's respite can be therapeutic, but using respite as therapy can make children resent it. That's what a lot of teens and young adults, autistics, have been saying. Respite is so important to them, more than therapy. But when they find that respite is part of therapy, it's there's a resentment that goes along with it.
Yeah, and I think what's coming up on this next slide are two of the most kind of powerful questions that you can ask as a clinician. So what are the child's strengths, and what do they like to do? These are such basic things, and yet I think in a model that for so long has emphasized deficits and fixing deficits, we gloss over these things, and yet they're so critically important. It's all free time should not be kind of booked up with therapy, and it's important for all people to develop kind of a rich, leisure skill set. I think discussing goals with the family and with the child, depending on their age and developmental level. Again, getting back to what are those emotions that are underlying this, and are you having this discussion up here, but that what's kind of behind it is this kind of stew of emotions down here. And then trying to provide some education. And so this was an example of sort of what I said to the family when we had the hand flapping discussion. Many autistic people describe that flapping their hands as a way to get their energy out or express themselves. Sometimes they aren't even aware of it. I tend to twirl my pen when I need to fidget. Do you have any unconscious habits? I would love to tell you that this worked. It didn't. But maybe a seed was planted there that will kind of someday help to foster that further knowledge and acceptance. Okay, so maybe kind of we can have a brief discussion on this one, but what are the different ways that you have seen families, seeking out cures? How have you had these discussions? What worked? What didn't? Anne. Oh, Anne, you're muted.
Thank you. One particular family concentrated solely on the fact that this girl was inattentive. They valued education, so ignored everything else. Her lack of socialization, her extreme shyness, her inability to ask any questions, in favor of just attention, and expecting that this would be just ADHD and that a pill would cure it. And it's been very, very difficult to open their minds to it being a more complex issue, even when the associated ADHD was not adequately treated with stimulant medication. So, but interestingly, I noticed that they have booked to come back. So that's reassuring.
That's that relational continuity that hopefully, it's a dialogue that happens over time. Okay, let's move on because I want to make sure that we have a lot of time to discuss this last one. So, what happens when we fail to accept autistic people? Um, so there is some emerging literature on this subject, and so there's a study out of 2017 published with autistic adults, and 41% did not feel they had been accepted as an autistic person in the past week. And this was, identifying that was significantly associated with depression and reports of stress. And they looked at internal and external acceptance. So internal was how you accept yourself, external being how other people accepted you. And that external acceptance, the perception of external acceptance was significantly associated with levels of depression, anxiety, and stress. And so this is just a figure from the paper. Again, you can sort of see that as that external acceptance rating is lower, the level of depression is higher, and then kind of goes down as the acceptance rating increases. And then similarly, the personal acceptance or that internal acceptance also follows a similar pattern. This is another study out of 2017 and had some more qualitative data, which I think are quite telling and quite rich in terms of what people are doing related to acceptance, non-acceptance, and trying to fit somewhere in that. And so I do not exhibit symptoms much or am able to mask or hide them almost completely. I have to invest a lot of energy into passing as neurotypical. I feel that I have spent the majority of my life engaged in the search for acceptance, and therefore I can fake neurotypical behavior pretty well. I mask well, so I am accepted, but not as an autistic person. So I think what comes out here, and these are such sad quotes for me, but even when we can't see the autistic characteristics or traits, it doesn't mean that there isn't cost. And that cost can be very high and can be emotional. It can also be cognitive and physical. So people can describe feeling physically exhausted as a result of their efforts of trying to diminish the ways that they appear autistic or pass as neurotypical.
And we can see that with younger kids a lot, because parents will talk about the fact that that schools say that the kid's doing fine all day, they're not having any issues. The kid comes home and everything just erupts, and they don't understand why there's such a dichotomy. It's because the child has learned how to fit in, but it's taking a lot of effort to keep that. So when the expectations are lower, when it's a safer place at home, everything comes out, and the ability to mask is completely shot. And sometimes it can take a little bit of time. With my kids, with two of my kids, there tends to be a honeymoon period when they're in a new situation where they're able to handle things and do okay. But after a couple of weeks, a month or so, everything comes off the rails consistently because they can't hold it together that long. They can't keep up that persona a lot.
Okay, so this is Paige Lale. I think, is that how you say her last name?
I'm not sure whether it's Lyle or Lale, but it's close.
Yeah. This is why, despite recent news, we should not cancel TikTok. Paige has put up a number of videos on TikTok about being autistic, and she does just a brilliant job describing it. Sometimes they have a few swears in them. So Matthew, I'm not sure if these videos do.
I think these ones are okay, but I'm not 100% sure.
Just a general kind of warning, but we thought we would play some of them for you. We can't hear that.
You go to the next slide and I'll see if I can go find it.
Maybe, Selena, it doesn't matter if you're muted.
If she stops sharing the screen.
Autism in
There
girls.
we go.
Oh, there we go.
When doctors were studying autism, they only studied males. This makes it harder for anyone else to be diagnosed because everything is based off the male brain. This sucks. Girls usually end up showing different traits than guys do, which is why it can take us years to get diagnosed. I was 15 when I got diagnosed, and that's considered early for a girl. I have a guy friend who's autistic, and he was 2 when he got diagnosed. A main reason as to why girls are so late to get diagnosed is because we are particularly good at one thing that guys are not so good at when it comes to autism. And this is something we call masking. Masking is basically just being like a really good actor. It's where you take traits that everyone else is showing and start portraying them as yourself. It's like a lot of copying going on. But in your mind, you don't think you're copying. You think that this is normal and everyone feels the same way that you do. You basically feel like an alien and you're really good at hiding that, which is why I don't seem autistic. Autism in Girls Part 2. This one's kind of about autism in general, but I feel like a lot of them are. But a lot of it is just like my opinion because I am a girl. Get high functioning and low functioning out of your vocabulary. It doesn't help anybody. I know you might think that like saying like, oh, you're high functioning is a compliment. It's not a compliment. It's actually like a reminder that I'm just masking, and it's so hard. Masking is the most exhausting thing in the world. It's my New Year's resolution actually to not mask. That means showing my autistic traits and not, pretending like I'm someone I'm not and just being more myself. High functioning is basically a label that you can use to be like, oh, your autism doesn't affect me that much. But I'll tell you, everyone you think is high functioning is greatly affected by their autism. Autism's already hard. Masking is harder. It's just like a little microaggression that is really, it sucks, okay? There's no such thing as high functioning and low functioning. We're all just autistic.
I love those. She again, similar to that Jim Sinclair quote, she's like distilled everything down into such a great little, bite-sized piece. And she also does makeup tutorials, but I can't keep up with them, so I just don't try. Okay, moving on. So how have you seen the impacts of non-acceptance in your practice? What has it looked like? I think for me, one of the other things that perhaps didn't get mentioned is that one of the ways it can show up in my practice is getting referred kids who are on just a ton of medication. And sometimes when we dig down, it's like, well, what what was the referring doctor trying to treat with, say, 70 milligrams of bifenthrin, which is a lot. And the answer was like, oh, he's very excitable, and when he gets excited, he does this. Which is, not a hyperactivity thing. That's a motor mannerism. That's, that is part of autism. And so sometimes we can get part of the way there too with a bit of education on that. I see Heather has a hand up.
Can you hear me?
Yep.
Oh, good. I'm using this super duper microphone today that I've never used before because I didn't want my dogs barking at everyone. First of all, I'd just like to say, Matthew, how wonderful it is that you make us so aware of all of these things you've talked about today. And it's been a real, eye-opener and real education. Thank you. And the impacts of non-acceptance in practice, I guess after just seeing Paige, I will never use high functioning again in terms of what I have just seen. But I think a lot of the great impact of non-acceptance that I saw, like I'll think right off the bat, 3 teenage girls, and they really suffered with anxiety and depression and sleep disorders and Zoloft, like it really, so maybe there could have been, in retrospect, now we're going back a bit, perhaps working on the discussion, like you don't really have to do all this anymore. If there was more acceptance, I definitely think that these 3 young ladies I'm thinking of, there's no way that they would have had the same level of stress and depression and sleep anxiety the night before they had to go to high school the next day, and how they were going to act, and so on and so on. So so that's, I guess, all my comments. Thank you.
Thank you. One of the things I've noticed, I've worked with teens a lot over the last in my adult life, and girls tend to be more accepting of guys with quirks than and guys sort of ignore or or push around guys that are quirky. But it's girls that are quirky, girls tend to have a real problem with, and it's really girls, especially through the tween and early teen ages, they're expecting everybody to be very similar. When they're younger, it's okay, but when they hit that tween, that 11, 12, 13 age, it's when a lot of girls, that's when a lot of girls start getting diagnosed, because they start having issues that they didn't have before, because the gaps between the social gaps between them and their other girls, the neurotypical girls, aren't as wide, but they get more, and not fitting in, not being the same, struggling with social things, having everything, the intensity of school and everything gets ramped up, and they start having the anxieties, they start having the depressions, they then start having behaviors that just didn't get seen before. And I have 2 daughters and 1 son, and my youngest is in that tween age, and this year, grade 6 was the hardest year. She went from not having behaviors, not having a lot of issues, like social issues, yes, social interaction, communication, she has a lot of stuff, but in terms of her sense of self was okay until this year. And then anxiety and depression and all these things happened because she couldn't fit in with the girls anymore. And the girls recognized that, and the girls started attacking her on that. And I think that's why it's there's a real difference between how girls tend to get diagnosed later, because it's they have to fit in until they can't anymore.
Well, that was a little triggering for me in remembering middle school. It's hard years. Okay, so I do want to. We'll have a few minutes open for questions afterwards, but I want to make sure we hit our take-home points. So, if you're a clinician and listening to this, I hope that you've learned something new, or you perhaps had something challenged. I think one of the things I try to balance as a clinician here is that, I cannot do the whole job of making someone accept, their child as being autistic. And I still have a lot of influence there. And so it's about kind of doing what you can, and also, recognizing that you can't get someone the whole way there necessarily. Language matters. Language is tough to change too, though, right? It's tough when we've been physicians and we've learned a very biomedical language. So think about it, be more aware, try changing it up here and there, and it becomes a bit more natural over time. I think understanding those emotions of grief, validating feelings, and providing hope does a lot of the work of kind of moving towards acceptance. Therapy, obviously, a nuanced discussion, significant implications, and maybe what you do is just kind of think about what your own perspective is on this, what your own language you use around this is, and think about some of the assumptions that perhaps underlie that, and let's move towards a language that can be a bit more specific in terms of what we really mean. And then watching for the fallout of non-acceptance. And I hope that we can also kind of celebrate the joys of acceptance too. And that is something that has probably been the greatest joy for me as a clinician, of seeing when it does work. This is a picture from Stephen Wiltshire, who, if you don't know his art, it's really spectacular. He is autistic and he draws spectacular skylines, with only having kind of seen them once usually. And then we have some references, and maybe if we go to the next slide, there's some books, because people were sort of asking for some books. But yeah, we have some time for questions or comments. I can stick around for a